I'm Harold Henderson. Began having problems with this nodule earlier this year. I didn't know I had one. I got a new doctor. She starts feeling on my neck and she says, "How long have you had this nodule?" And I said, "What nodule?" And then I started to feel it. So now, I'm freaking out a little bit, and she says, "You need to get that checked out." So I came to Dr. Leal. She did an ultrasound, confirmed that there was maybe 2 or 3 nodules there, had a biopsy done, confirmed that it was benign. So that was great news, but we definitely needed to do something about it. I could tell my voice was changing. Periodically, it would feel like someone was choking me. Once I started doing my YouTube research, I realized the importance of the thyroid and how much it regulates. I had 2 options. I guess I could either have it surgically removed, compromise a third of my thyroid, and I'd be on thyroid medication for the rest of my life, or have this procedure done, which would save my thyroid. Discussed it with family, and we elected to go this route.
If you're an athyroidic individual, it's very, very hard to get the thyroid medicine adjusted. You have nothing in your system to fine-tune the thyroid hormone whatsoever. Huge difference. Of course, if you save the whole thyroid, you're even better off.
Right. It's very promising. I really enjoy seeing that we're able to save thyroids and able to prevent aggressive surgery in patients.
Besides the choking, it's the voice. I don't like to hear my own voice now. I can't communicate as effectively as I could before. Yes. I have a very good patient-doctor relationship with Dr. Leal. I could tell she was very passionate about this. Put no pressure on me, let me make the decision. I felt more empowered. If it's like the biopsy, then I'm fine.
It's very much like a biopsy.
I said, let's rock and roll.
Let's get this nodule taken care of.
Yes.
You're in Nashville?
Yes.
Oh my goodness. So many patients have been asking, is there someone in Nashville who offers RFA? And I've always had to say no. You're going to make a lot of patients really, really happy.
We're sort of a unique duo. I'm an endocrinologist with lots and lots of years experience. Practiced in the same place from 1979 until 2019, From about 1990 until now, it's like, gosh, I wish they'd get the RFA here so we can do it before I retire. I finally said, well, I guess I'm just never going to get to do that part of interventional thyroidology. But most of my practice for the last 20 years before I closed my office was thyroid. Lots of biopsies, lots of thyroid cancer management. And of course, when you do it for that long, you get the idea like, well, wait a minute, why are we taking out the whole thyroid for a 9-millimeter papillary carcinoma? And this lady's got a scar and she's hoarse for the rest of her life,
It seems a bit extreme, doesn't it?
And it's basically the same operation that the Mayo brothers, invented in the 1920s. It's pretty much the same procedure for 100 years.
I did not know that.
So I closed my office in 2019, having lamented for 15 years about not having RFA. And then I missed it, so I started supervising 2 nurse practitioners. In Tennessee, we have this law that says if you're an independent nurse practitioner, you have to be having 20% of your charts reviewed by a physician. 2 nurse practitioners who both practiced endocrinology, they said, well, why don't you supervise us? I did that, but that was kind of boring, just looking at charts. And I finally said, you need to do something more than diabetes and occasional hypothyroidism. Why don't you get an ultrasound? Both of these nurse practitioners, one of which was Luisa, said, well, all right, why don't you bring one of your old ultrasounds, which I had in storage. So I brought it over, and then we started doing ultrasounds. And then I said, well, yeah, if you're going to do nodules, you might as well do biopsies. And then they said, if you're going to do nodules, you might as well do cyst aspirations and what's called alcohol installation in cysts. Once we started doing ultrasounds, then they said, well, why don't you come and see some of the more difficult patients, the ones who had cancer? So then I started seeing patients again. One day, Louisa surprises me and says, guess what? You kept complaining about never having RFA, so I bought one. And I'm like, what? She said, yeah, I bought one. And then about 6 months later, she bought another ultrasound, and she said, yeah, we're going thyroid all the way. I'm not fully retired, but retirement could be around the corner in, say, 2 to 4 years. So I wanted to teach her my ultrasound expertise. But then at some point, I'll be out and she'll be doing it. She'll probably be the first nurse practitioner to be doing it by herself. Right now, we do them together. So it's a little different than probably most of the people that you know who are doing this.
I don't believe I've encountered any nurse practitioners doing this, but I think that it's amazing that she has access to you and all of your years of experience to be her mentor. That's tremendous.
The future of endocrinology is nurse practitioners. It's not MDs. I chose to supervise nurse practitioners because endocrinology is a specialty, and mainly a diagnostic specialty done by MDs, is just gradually disappearing. If you want to be an endocrinologist, you just have to love figuring out things more than you love your bank account. You do 4 years of medical school, 3 years of internal medicine residency, and 2 or 3 years endocrine fellowship. And then when you get out, unless you're an interventional thyroidologist, which has taken me my whole lifetime to get there, but unless you're an interventional, you're using the same codes that internal medicine and family practice are to bill for your services. But this has a huge impact on how much training people are willing to do. Why should you train and start seeing your own patients at age 33 when you could start seeing your own patients at age 26 and make 80% of the income? Health insurance doesn't help this because endocrinologists, they're usually at the forefront of their field, and they like to bring new things in, like RFA, for example. If you're at the forefront of your field, you're constantly having to fight getting insurance approval for stuff too. So anyway, a lot of people are just saying, well, I can do mostly diabetes and some thyroid and be fully employed at age 25 or 26. I decided a long time ago, if there's going to be anybody out there who's going to be an endocrinologist, we're going to have to work with the nurse practitioners. And it's interesting, ACE has completely redone their whole identity so that their growth can come from nurse practitioners. Their website, their training programs, everything is oriented towards PAs and nurse practitioners and not towards physicians. I don't know, I'm curious to know how many of your people that you've met who are doing this are actually endos?
I would say probably about half of them. A lot of them are endocrinologists. A lot of them are ENTs, and a very small minority are interventional radiologists. All these different specialists can kind of come into this area, and they all have a skill set that lends to it, but it's all different too.
Yeah, I think the common feature of the skill set is being able to image the thyroid with ultrasound.
Yes.
And being able to do it backwards and forwards, right-handed and left-handed. That was the easy part for me. That was the hard part for Luisa because she wasn't used to imaging.
So let's go back. You were talking in the beginning about how Luisa bought the equipment and then brought you in to start learning and doing this procedure. What does that look like in the day-to-day when you're treating patients?
It's definitely a unique arrangement. The office is closed on Fridays, and so we'll set up one room in the office just for an RFA room. And we'll set out table with trays of instruments and the RFA machine over in the corner, and we move a table in. So it looks kind of like an operating room. I'll do the initial localizing ultrasound. We'll review where we're going to go. A couple times I actually made clay models.
This was a guy who had a huge nodule.
Wow.
This is pretty much all that was left of his thyroid on the right side. This is the conceptual approach. We call these conceptual ablation units. Put the needle in and then you turn on the juice and you withdraw. Then you do the next one. Then you do the next one. This nodule was so big we had 2 entry points, and that's what these lines are. We had an entry point here, we went boom, boom, boom. And we had an entry point here, and we went boom, boom, boom.
Oh, wow.
Okay? And we try and leave, of course, the normal thyroid alone, which is how you save your thyroid.
Exactly.
S1T.
And then I'll do the anesthesia, maybe the first half of the nodule. By then, I'm getting kind of tired. My back's starting to hurt. And we'll switch, and I'll be first assistant, and she'll be doing the rest of the ablation. So it works out fine that way.
I think that's a really great team approach, having your experience and then her learning while you're doing.
And she's actually done as many RFAs as I have. She has made herself a specialist on the machine. I don't have to worry about that. I don't have to go over and keep checking the settings and all that. It's working for us.
The lower unit with the big screen on it, that's the radio frequency, the blue one. And, of course, the power comes in from the wall, and then there's a special little connector that goes to the radio frequency ablator that screws into that. You need any help over there? Are you good?
Yep.
Okay.
you feeling?
Feeling good. Man, that nap was good. I'm satisfied.
So you did really well.
Good.
You did amazing.
I slept through most of it.
You took a nap. How did you feel when you were awake?
It was about the equivalent of an ultrasound. Felt a little pressure, but it wasn't uncomfortable, it wasn't unbearable. It was nice to hear the medical professionals communicating with each other. They seemed to kind of flow with each other. One knew what the other one was doing or anticipated the next move. They seemed to know what they were doing.
They're a good team.
Yeah. I took a good nap and I was almost mad when they woke me up, you know. They said it went well. I'm anticipating a speedy recovery, so I'm gonna take it easy the next day or two and I should be good to go Monday.
Harrold, I'm glad that everything went well, and thank you again for letting me.
I wish your audience, watches this and appreciates the effort that was put into it, because hopefully it'll save my thyroid.
Save your thyroid.
Since the procedure, I've not felt any discomfort. I've gone back for a follow-up. Ultrasound was used to measure the effects of the procedure. I believe I had 4 nodules that were treated. 3 have decreased in size noticeably, and 1 has maintained its size. Dr. Leal was pleased with the results. I'm pleased with the results. It certainly met, if not exceeded, my expectations. I was most grateful to her finding the issues and addressing the issues. It was worth it. It was money well spent. I did not want to be on a lifetime of medication. I'm on enough medication, so 1 less was something I was looking for.
I wanted to ask you a specific question about your voice.
I don't like to hear my own voice now.
So how's your voice doing now?
It's great. I don't hear myself having the hoarseness, so that concern was eliminated. I could not be more excited about the outcome. Dr. Leal, she was one of my favorite doctors. I got a sack full of doctors. It's a good drive from where I live to where her office is. I don't mind that drive. I look forward to it simply because she cares. I'm just tickled to death, and I hope anyone who is considering the procedure, do yourself good when it's something that is very safe, and in my case, I feel very effective. It was a good choice. I think it was one of the best decisions I've made. Do your research. More importantly, make an appointment. Sit down with your clinical professional. This is not a paid endorsement. I hope there are thousands of others out there. Look at videos like this, and I appreciate the work that you're doing trying to get the message out, because there's just not enough information on the subject. It doesn't get headlines like some other diseases. I appreciate what you're doing to try to get the word out.
This is something that impacts about 70% of people in their lifetime. That's why I started the Save Your Thyroid community back in 2019. There was no patient-oriented resources out there to help me understand what I could do besides having surgery. This needed to be put out there for patients to be able to find information that was oriented towards them. That's what this is all about.
When you think about the long-term effects of thyroid surgery, thyroid medication for the rest of your life, the cost of that, it's like, okay, I can either pay now or pay later.
Yes.
Which do I want to do? Anything to avoid those side effects and long-term health consequences, I'm in favor of.